Assalamu alaikum wa rahmatullahi wa barakatuh. Greetings everyone and good evening. I am Anas Dajani and again, I'll gladly be your host for the day. The Saudi Prosthodontics Society would like to welcome all of the participants in our fifth day for this week and to thank all of you for your continuous support by attending our webinars. We hope that you gained useful information from our previous speakers and we will continue to deliver more lectures in the days to come. A lot of requests has been made in regards to obtaining certificates for attending these online lectures. A recent tweet was made regarding this matter. Please follow our Twitter account at Saudi Prosto for more information in this matter. As for now, we are really proud to announce our next speaker who happens to be one of the Saudi board residents with a really interesting topic, Dr. Abdulaziz Alshamlan. Dr. Abdulaziz Alshamlan has completed his Bachelor of Dental Surgery at University of Dammam, currently Imam Abdulrahman bin Faisal University in Saudi Arabia in 2012. He finished his advanced training in orofacial pain from Rutgers School of Dental Medicine, New Jersey, US in 2014. Currently, he is a third-year Saudi board in Prosthodontics at Knig Saud University. Dr. Abdulaziz, the mic is yours. You can unmute yourself and start sharing your screen, please.
Bismillah ar-Rahman ar-Rahim. Thank you, Doctor, for your introduction. Good evening, everyone. It's my pleasure to be here today as one of the speakers, in this scientific activity organized by the Saudi Society of Prosthodontics. And my name is Abdulaziz Alshamlan, and I am a senior prosthodontic resident. And today I'll be talking about a different aspect of prosthodontics. I'll be talking about the extraoral prosthesis and revealing the hidden option. And before I start, I would like to thank the Saudi Prosthodontic Society for giving me this opportunity to be presenting during this scientific webinar. So we all know that prosthodontics is a multidisciplinary specialty, and we have multiple subspecialties within this original specialty. So we could work either as a removable prosthodontics and fixed prosthodontics and implants and maxillofacial prosthetics. And each specialty has its own unique features. So I'm going to talk about the maxillofacial prosthetics in order to show this hidden option. So when we talk about replacing a missing part in the maxillofacial region, this is basically what's called, or what does the maxillofacial prosthetics mean. So the prosthesis could be moved or not, could be removed or not. And based on the defective region, the prosthesis is named. And usually the maxillofacial defects are classified into congenital and acquired based on the causes. And for the sake of today's presentation, I'm gonna present one congenital maxillofacial defect, which was treated with an extraoral prosthesis, and the other case is an acquired traumatic injury that also was treated with an extraoral prosthesis. So before I start introducing my cases, I would like to talk about Treacher-Collins syndrome. So starting with the history of this syndrome, in 1900, this ophthalmologist, Dr. Edward Treacher-Collins, was the first one who described this syndrome based on its essential traits. And then in 1943, these physicians, Adolfo Franschetti and David Klein, they started describing this syndrome as a mandibulofacial dysostosis. So Treacher-Collins syndrome is considered as a rare congenital autosomal dominant disorder that result from an abnormal development of the first and second brachial arches. Usually the life expectancy is normal and the IQ of these patients is normal. And by the way, this the boy in this photo, he was the actor in the Wonder movie, and he act like if he had this syndrome, just to show how much these people are getting bullied by others. So we have the general clinical features of this syndrome. We have the facial asymmetry, and we have the coloboma of the lower eyelid, and the external ear deformity, and the bird or fish appearance like. And one of the most common malformation is the facial bone malformation. And the zygomatic complex hypoplasia is considered as the major hypoplasia that that occurs in the face, and it accounts for 81% in the cases. And we can feel it when we diagnose the patient in the zygomatic area. We can feel that there is a depression, and this could be explained by the absence of the bone or because the bone is smaller in size. And we have also 85% of the patients, they have bilateral microtia, which is a deformity in the external ear. And usually it is classified into 4 grades based on the severity, where grade 1 indicates that the external ear is almost normal but smaller in size, while in grade 2, the external ear looks normal just from the lower half. And grade 3, the external ear is just about a piece of cartilage. And then grade 4, which is the most severe grade, which is the total absence of the external ear and the ear canal. And it's also called anotia. And then we have the dental and oral abnormalities, such as the cleft palate and the retroposition tongue and the steep occlusal plane. All these malformations and abnormality will affect the patient's speech and will affect the patient in aesthetics and in function. So I'm gonna start my case with my patient's personal data. So she is a 22-year-old Saudi female patient. She presented to the clinic. She complained from her previous prosthetic auricular prosthesis. And she complained that it is not retentive anymore. And she mentioned that she's not happy with the position of the prosthesis. And she mentioned one main thing, that it has an interference with her bone hearing device, which is called the BAHA and stands for bone anchored hearing aids. But by looking at the clinical photos, we can see that the patient has bilateral ear deformity, and she has a grade 4 microtia, and she has a conductive hearing loss. And 8 years ago, she underwent through the bone anchor hearing aids device. So this device is going to help her to hear. And for the missing ear, they were replaced by a bilateral implant retained auricular prosthesis 6 years ago. And just to give you a quick hint about the extraoral implants, they are just similar to the intraoral. They are similar to the osseointegration concept of the intraoral implants. So the same concept applies here and there. And the difference that the fixture length is 3 to 4 millimeters, and the diameter ranges between 3.75 to 5.5 millimeters. So it's basically wider and shorter than the regular implants. And I would like to say that Branemark was the first one who placed both the bone anchored hearing aids and the extraoral implants in the auricular region. And that was in 1977 and 1979, respectively. And here we can see the extraoral, we can see the extraoral implants, how they look like. And usually we can place it in the auricular area or the nasal area or the orbital around the eyes. And also we can notice that the survival rates regarding the extraoral implants, it's considered, the auricular implant region is considered as the highest survival rate, which is considered as 98.8%. And usually 2 implants are enough to retain an auricular prosthesis. By placing them in the mastoid bone and the temporal bone, forming a position of 8 o'clock and 10:30 on the right side and 1:30 and 4 o'clock on the left side. And usually the distance between the implants and the external determinators should be 1 centimeter at least. So the same concept applies on my patient. So we use this clock as a common language of communication between the surgeon and the maxillofacial prosthodontist and the anaplastologist in order to discuss and diagnose the case. So my patient on the right side, her implants are positioned between the area of 8 o'clock and 11 o'clock. And on the left side, they are positioned between 1 o'clock and 3 o'clock. And this is almost considered as a favorable position. And this is how my patient looks with her previous auricular prosthesis. And as I mentioned, she feels that it is a little bit posteriorly rotated and it's interfering with her bone hearing device. So she cannot wear it while she's wearing the auricular prosthesis. So she cannot wear both of them at once. And these are the presented auricular prostheses of the patient. And they were made from a CAD/CAM mold. So we talked about the extraoral implant that retain our prosthesis. So what are the means of attachment or retention for our prosthesis? In case if there is no implants, we have adhesives, such as the silicone-based adhesives or the water-based adhesives. And we have the bar framework and the magnets. So another question will arise. So that is, which one to use? Is it the bar or the magnets? Well, according to this systematic review by Brandau, he compared the bar clips versus the magnets. And they concluded that both systems will not affect the treatment outcome, but the magnets showed fewer complication when the magnet showed fewer complication than the bar clips. And in another prospective clinical study with a 3-year follow-up by Visser, they concluded that 59% of the patients, they preferred the magnet over the bar clip. And the reason was, it is easier to remove and insert, and it is easier to clean and to take care of. So they can maintain the hygiene measures. So whenever if we need to fabricate an auricular prosthesis, we should go through these steps, starting with the impressions, ending with the extrinsic coloration. So, and I'm gonna go through these steps, and I'm going to reflect it on my case. So for taking the impression, we have 2 ways. One way is to put the patient in a supine position and ask him to turn on the right side, on one side. And then we adapt the boxing wax to the desired area, which is the auricular area. And then we place our alginate impression material, and then we reinforce it with paper clips and plaster. Or we have the other way, which I did by using the light and regular body polyvinyl siloxane impression and reinforced with Q-tips. And then after removing the impression, it was marked. I marked the upper border of the impression and the border toward the nose. So when I pour the impression, I will not get confused. And then an acrylic superstructure framework was fabricated to verify the position, to verify the location of the implants, and to do the magnet pickup in the clinic using the light cure material. And this is how the magnets look with the acrylic superstructure after the pickup. Or we have another way, by placing the magnets over the implants and taking an impression. So now the magnets are transferred to the impression. Then we bring the implant replicas and we attach them to the magnet in the impression, and we pour the impression. So what we did now is we transferred the exact position of the implants. We transferred the exact position of the implants from the patient to the cast. And another acrylic superstructure was fabricated and it was verified on the patient face, and we tried and it was done in the lab. I didn't do it in the clinic. And usually this part will be embedded later on with the silicone ear. So the wax up was made, and the acrylic superstructure was attached to this wax, and it was tried on the patient's face. While doing the wax trying on the patient's face, we check from the frontal view. We evaluate the projection of the ears, if we have to reduce it or if we have to increase it. And this is basically depending on the patient's opinion. And from the lateral views, we evaluate the position and the orientation of the ear. And usually the ideal position should be in the middle face between the eyebrows and the base of the nose. And I made sure that the patient is wearing her bone hearing device to make sure that if any interference existing, but alhamdulillah, there was no interference now. And then after the patient approved the shape and the position of the waxed ears, we started applying the color. We started choosing the color. And usually for choosing the color, we have two ways. One way is to use the SpectroMatch. This is a device that we use this device usually gives you the exact colors that you need to mix in grams in order to get the desired basic skin color. Or we have, again, the conventional way, which I followed by using this clear silicone and the multiple coloring system. So what I did exactly is I established the basic skin color of the patient. And then for specific areas in the ear, such as the helix, I added a reddish color to the silicone. And for the anti-helix area, I added a yellowish color. I created the silicone with a yellowish color. And then it was the time to create the three-piece mold. So the three-piece mold was created starting with the first piece, which is the cast. We create retentive grooves, and we create these channels to facilitate the passage of the silicone in order to avoid the bubbles. And then the second layer is used just to block the undercut behind the external ear. And the third part or the third piece comes over the first and the second pieces. And this is how our mold looks like after the wax elimination procedure. And then we started applying our silicone layer by layer using the brush. Usually in the helix area, the silicone with a reddish color was added, and in the anti-helix area, the silicone with a yellowish color was added. And for the remaining sides, I used the basic skin color of the patient on the margins and all around. And then we pack it until we start seeing the passage of the silicone start at, and usually we pack it, and then until we notice that the silicone started to get out through these holes. So we stop packing and we wait until it sits. And usually the types of silicone that we use in the medical field and dental field are the We have the room temperature vulcanization, such as the maxillofacial prosthesis or the limbic prosthesis. And we have the heat temperature vulcanization, such as the medical catheters that is used after the surgical operations. And so we have the ear now, and it's ready to be inserted on the patient face to evaluate the position and to evaluate the color. So it was placed, and this is the frontal view of the patient with the lateral views, and this is my closer view of the silicone ears. And we can notice, it is a little bit lighter. So it's time now to add the extrinsic coloration. And usually for the extrinsic coloration, we have 4 main colors. We have the red, and we have the red color, which will be applied over the helix area, and the yellowish color, which will be applied over the anti-helix area, and the blue color, which will be applied in the deep areas of the ear, of the prosthesis, and the brown, if we need it, we apply it all over, all around, and over the margins. And this is how my auricular prosthesis looks like after the external coloration and after piercing. And this is the frontal view of the patient, and this is the lateral views of the patient with the final auricular prosthesis, and this is a closer look of the auricular prosthesis. And the patient actually was happy and satisfied, and I gave her the post-operative instruction to maintain this auricular prosthesis. So let's talk about the next case. The second case, as I mentioned before, that it's an acquired traumatic case, which was replaced with an extraoral prosthesis. And since it is an ocular prosthesis, I would like to talk briefly about the history of ocular prosthesis. So we have this French surgeon, Ambrose Berry, was the first one who published the use of the ocular prosthesis cases, and he used the gold and silver material to replace the missing parts. And then he replaced these materials with glass. So in 1940, the glass ocular prostheses were replaced with an acrylic ocular prosthesis because it is more compatible and friendly to the surrounding tissues. And usually, before we fabricate any ocular prosthesis, it is recommended to the patient to go through one of these surgeries, which is the effusion, which is removal of some contents of the eye, and inoculation, which is removal of the globe, or excentration, which is total removal of the eye, and including the soft tissues surrounding, such as the muscles and the nerves and the lacrimal ducts. But according to study by Pine et al. In 2015, about the scleral shell prosthesis and prosthetic contact lenses, he mentioned that most of the patients, they develop a psychological trauma after the after the surgical removal of the eye. And he mentioned that whenever if the eye is non-functioning, and it's non-painful, and it is smaller in size, it is better to keep the eye without doing any surgical removal, so we can avoid the psychological trauma following the surgery, and we can retain it with a scleral shell prosthesis, and the eye itself will be retaining this shell appropriately. And this concept was applied on my patient. So my patient is a 36-year-old female. She's a Saudi, unemployed, she's single. She complained that she has a vision problem in her eyes, in her right eye exactly, and she mentioned that she had a direct trauma to her right eye. And since that time, she lost her vision. And she was complaining that she's not happy with the dissimilarity of both eyes. So as we can see that the eyes, as we can see that there is a big difference between the right eye and the left eye. The right eye is really smaller than the normal eye. And we can check again here from the side views, we can check the socket fullness. We can see that the right eye is not filling the socket as the normal eye on the left side. So what I did is I took impression using the ocular stock tray, and by the use of the light body polyvinyl siloxane impression material, I placed it inside I placed the tray inside the socket and it was adapted according to the socket. And then the impression was injected, and I made sure that the injectable material was enough by noticing the excess material coming out of the eye. And this means that the eye socket is now full with the impression material. And this is how the impression material looks like after removal. And then it was poured into cast to fabricate a wax layer for the wax try-in, to do our try-in. So I did the try-in, and usually when we do the wax try-in, we check the borders and we check the stability of the wax, and then we evaluate the opening and the closure of the eye. So in order, if we need to increase the opening or to decrease it, usually we remove the wax from the middle part of the wax, not from the borders. Because if we removed from the borders or we added, the wax is gonna be just overextended or underextended. It has nothing to do with the opening and the closing. Opening and closing will be just from this part, the middle part of the wax. And then it was the time to locate the exact position of the iris. So what I did is I measured the distance from the facial midline to the medial aspect of the iris of the normal eye. And then I transferred it to the wax. So after locating the medial aspect of the iris, I attached this plastic iris disc. I attached it to the wax, and then again I tried it on the patient's face to check the position and to check the socket fullness from the side views. And after it was approved by the patient, I started my processing procedure. It's just like the complete denture procedure. But the most important thing here is that we have to keep this sprue. We should not remove it because it's gonna save the exact position of the iris during the wax removal procedure and during applying the acrylic material. And then this is the acrylic. This is the ocular acrylic prosthesis after processing and after polishing and finishing. It was tried again on the patient face to evaluate the position of the iris and to evaluate the fit of this ocular prosthesis over the eye. And now it's time to start giving this ocular prosthesis more natural look. So we'll transfer it from a solid look to a dynamic look. And usually all scleras have blue and yellow and red colors. So usually we mix them and compare it with the natural teeth, with the natural eyes. And then we add some cotton. So after we finish the coloring procedure, we start adding the characterization to give it a more and more natural look by adding some cotton wool fibers to mimic the blood vessels in the natural eye, in the normal eye of the patient. And then after we finish adding this procedure, it's time to remove the ocular sprue, and we should add now a very thin, clear acrylic layer just to give the ocular prosthesis a soft and shiny appearance. And this is my final prosthesis inserted in the patient's eye, and the patient was happy and she was satisfied. And this is the picture in the left, the upper picture in the left side shows how the patient how the patient came to us and how the patient left us. And it is very important to give these patients the instruction about how to remove the prosthesis and how to insert it in order to maintain the good hygiene measures. And usually the post-operative instruction for the ocular prosthesis, we should instruct the patient that they should not remove it every day. Usually, it's the more they wear it, the better. The better results will be. So the eye is gonna get adapted to it. Usually, they should remove it once a week, and they should wash it with a mild soap so it will not get cloudy or to avoid any pitting appearance on the outer surface of the ocular prosthesis. And usually, during swimming, these patients should not open their eyes while swimming, or they should wear goggles, or simply they just remove it. And every 6 months, they should come back to the dental clinic to evaluate the surrounding tissue and to check if we need to do any polishing for the ocular prosthesis. And there is a study by Douglas Gollard et al. About the quality of the life of patients with facial prosthesis. And they stated that these patients with facial prosthesis, they had an improved self-esteem and increased quality of life because of the functions, because of the aesthetic function of these facial prosthesis. So I would like to say that aesthetics is not limited to the intraoral prosthesis. It's really important in the extraoral prosthesis in order to give the patients a natural look, so they won't feel that they have something different than the others, so they won't feel that they are inferior to others. And by this, I would like to acknowledge and say thank you very much. And I would like to thank Mr. Abdurrahman, our maxillofacial technician. And I would like to say thank you for Dr. Talal Nassar, my program director. And I would like to thank Prof. Walid Sadiq, my clinical instructor. And I would like to thank Dr. Nadia Al-Angari for giving me this chance to share these cases with you. And of course, I would like to say thank you to my colleagues for their support and their kind words. And I would like to thank you for attending my presentation today. And thank you for the Saudi Prosthodontic Society for giving me this opportunity again. And this is my email. In case if you need any information, I will be more than happy to reply. And thank you very much.
Dr. Abdulaziz, thank you so much for your amazing presentation, outstanding management and excellent outcome. Such a life-changing procedures that you've done. It is great to show the audience about the hidden aspect of prosthodontic specialty, and I'm really out of words to thank you enough. Thank you for stop sharing your screen. And now we will go to the question and answer. You can find the questions and answers in the Q&A section. Please, doctor, before answering any question, I would like you to press on that type and answer and just press any letter for the audience to see the question that you're about to answer, okay? And just wait, I want to share some. Okay, so as usual, this would be Dr. Abdulaziz's question, and few minutes from now, you're going to see the question in our Twitter account. So please vote for the right answer, and as well reply the right answer in the same tweet. Dr. Abdulaziz, you can unmute yourself and start answering the questions if you may. Thank you so much.
Thank you, Anas. And I will start looking now at the questions. One question here. Did you think regard doing the cases in a CAD/CAM technology? Well, yes, I would love to do it with the CAD/CAM technology, but unfortunately it was not available to me. So that's why I followed the conventional way. And one question here, how long did it take to create the auricular prosthesis and how many visits? Usually I cannot give you a specific number of the visits, but it really, it's a clear steps so that we can follow. So we can finish with, so let's say the first visit is the impression, the second visit is the pickup, the third is going to be the wax up, try-in, and then after choosing the color, usually the try-in will take more than 2 visits. And then choosing the color and then the insertion. So it's going to be almost 6 to 8 visits. I think it's going to be enough. And could you mention the post-operative instruction? Okay, regarding the auricular post-operative instruction, we can say that I would say that the patient should clean it. Usually should clean it on a daily basis. This is one thing, and the second thing, that the patient should not sleep using it because it might get torn while the patient is moving sideways. And usually we can, and during the sleep time, the tissue will be allowed to recover again. And we should avoid the excessive exposure to the sunlight because it's going to be faded. And we should avoid, and the patient should avoid mixing the prosthesis with the personal stuff, such as the makeup, such as the pen, so it won't get stained. What was the connection? What was the connection in the mentioned study between the ocular surgery and the psychological effect on the patient? So usually these patients, when they go through an ocular surgery or when they remove their eye, usually they will look. There is nothing in this region, so they will look different, really different than the others. So this will cause the psychological trauma for them. They will feel depressed. So some way, although they enforce to go for these surgeries, but in case if it's available to avoid it, so it's better too. Again, the post-operative instruction, I think I answered this question. One question here is, what is the survival rate of the extraoral implants compared to the intraoral implants? Usually, if we compare the whole extraoral implants, when we talk about the survival rate, I would say that usually the survival rate of the whole extraoral implants, without specifying any region, usually the extraoral implant, the survival rate will be 90%, 93%. 93%. So it is lower than the intraoral. It is lower than the intraoral implants, which is 95. Is the extraoral prosthesis as part of the Prosthodontics residency program? Yes, I would say yes, if the case was available or if we have it. Yes, we can. It is considered as part of the Prosthodontic residency program. How often do we need to change their prosthesis? Well, regarding the ocular, we can evaluate it every year. So if we have to do either we do like a rebase or a reline procedure, or we just change it once every year. And regarding the auricular, every 3 years we should change the auricular prosthesis, because usually it gets torn and it gets distorted. The color usually in the silicone is not stable. What are the instructions given to the patient with auricular prosthesis? I already answered. Is the ear made from acrylic or silicone? No, it is made from silicone, but usually the acrylic superstructure that I did the pickup with is embedded inside the silicone to give a more surface area of adhesion between the acrylic and the silicone. My question here: what are the means of retention of for the ocular prosthesis? What I did is just I mainly depend. In my case, I depend on the patient's eye itself. It's considered as an appropriate mean of retaining. One of the appropriate ways to retain the ocular prosthesis is to be maintained by the eye itself. But we have another, and usually the other mean of retention, usually the implants. And one question here: did you scan the prosthesis to be printed or milled in the future for replacement in case of tearing or discoloration? Usually, in this case, no, but usually most of the cases, usually we create like a bank of auricular cast and auricular duplicates, just to provide the patient immediately with the wax up. Are there any other types of extraoral attachment, and what is the best one regarding the efficiency and quality of the attachment? As I mentioned, if there is no implant, we can use the adhesives, and we can use the magnets and the attachment framework. And now the recent studies now are aiming toward the magnets, because it is easier to be manipulated by the patient, and because the new type of the magnets is really better than the previous one. Do you anesthetize the eye during the impression or try-in? No, because the patient already doesn't feel anything. What labs will do those procedures? I guess any lab with maxillofacial technician will do these procedures, the lab procedures. Would you recommend the patient to wear glasses afterwards? Yes, I do, but since the patient has it's not a big defect. There is no soft tissue replacement, so I guess it's fine. It's better to wear the glass to mask any defect, but I think it is I think it's fine if the patient did not wear it. And do you have intentions to do digitalization in the future? Yes, I would love to. After removal of the disease or traumatized eye, how many weeks are needed to recovery for the recovery of the eye socket? Usually it takes 4 to 6 months. And after removing the eye, usually there is like a prosthetic piece should be placed in the patient eye. It's called the conformer. Sorry, it's called the conformer, just to save the space and to keep the space for the next prosthesis. In case of ocular prosthetics, she already lost the vision, so she cannot also see. Yes, I agree. She doesn't see, but she doesn't look this way. She doesn't want to be. She doesn't want to look this way. So that's why she came to us, because she's not happy with her appearance. Why removing the eye in the second case? I did not. Usually, in my case, the eye was not removed. But usually, if the eye is blind, sometimes it is painful, and sometimes it is difficult to fabricate sometimes there is no space to create my prosthesis. So the minimum space usually for the scleral shell is 1.5 millimeter. So if we don't have this space, we should go for surgery. Types of adhesive you recommend with the auricular prosthesis? Well, to be honest, I don't recommend the use of the adhesives, because it's always better to go for implants and bar or magnets. But regarding the adhesives, in case if we are not able to place an implant, for the adhesives, it's better to use the silicone adhesives. One question here, and I think it's most of the questions are repeated except one question: why the survival rate of the ocular implant is high comparing to the others? Usually the auricular area, there is a good amount of bone volume and quality. So the bone quality in the temporal bone and the mastoid bone is very good. So we have good quality and good volume. This is one thing. And the other thing, usually it's away from the radiation area. So most of these patients, they get cancer. Some of these patients with extraoral defects, they are exposed to radiation. And usually the ear is the least area of radiation. So that's why, and I think this is why the survival rate is really high. And I think most of the questions are repeated. So thank you very much, and thank you for your attention.
You're most welcome, Dr. Abdulaziz. Thank you so much. Dear audience, try to visit our Twitter account, and as I said before, answer with the right answer in the vote of the same tweet, and also reply in the same tweet with the right answer. And we will see you, inshallah, tomorrow with our last speaker presentation with Dr. Khalid Al-Zahrani for this week. Thank you so much for your attendance, and have a great night. Bye.